Well, hello everyone. Welcome back to another interesting case. I have with me Andrew Lateplo. Andrew is my fellowship director here at Mass General Hospital. Gracious enough to talk to us about one of his cases that we talked about today, and it was too good to pass up. So, Andrew, thank you for coming to talk with us.
Sure, Scott, anytime.
So, tell us about the case. What happened?
I'm always happy to talk about lung ultrasound.
Yeah, I know you like
As
lung
you know.
ultrasound. Yeah.
This is a 98-year-old lady I saw the other night who came in with severe hypoxia, no pulmonary history, and daughter called EMS because her mother was having some trouble breathing. EMS found her with SATs in the 70s, which improved to the low 90s on supplemental oxygen. She came in, she was tachypnic to the 30s, tachycardic and irregular to the 120s. She did have a history of AFib. She was afebrile and in moderate respiratory distress, normotensive. On exam, she had clear lungs, a little bit of symmetric edema bilaterally. And so we went right to her lungs because she's hypoxic, and the answer is in the lungs. So this is the right anterior chest wall, zone 1.
And this was done, EMS had just dropped her.
I think she was still on the ambulance stretcher, and she just looked that sick. So we just said, let's just look and see what we got.
So clearly you can tell you have this black anechoic fluid, so this is more likely an effusion anteriorly.
Good.
And then you have something behind it that maybe tissue, hard to tell.
Okay, so let's look at a slightly clearer picture.
So this is a little easier. You have, again, the anterior effusion, the anechoic fluid. And then distal to that, you have, looks like either a mass or consolidation with some nice air bronchograms here. They're hyperechoic, and that's what air looks like in the middle of
good. So
tissue.
It's classically called hepatization, and this isn't totally perfect, but you can see that this starts to look a lot more like a liver than it does lung. We do not really see so many bronchograms peripherally. They're all kind of located here centrally, so not really sure what to make of that. But within your differential, as you mentioned, would be the most common thing that would a 98-year-old female would get for consolidation of lung would be.
Yeah, it has to be pneumonia.
Pneumonia, right. So right now, do you want to give her any medicines? Do you want to treat her?
Well, even though she's not febrile, based on how ill she is and misfinding, I think you have to start antibiotics.
Absolutely. So right there, at time 1 minute into her visit, we were able to start antibiotics. We know about the golden hour in sepsis, how ultrasound can, how antibiotics can make a big difference. Note also, most pleural effusions you don't see anteriorly. So the fact that it's coming all the way anteriorly suggests that it's not a small one, it's a large one.
But I'm sure you looked at another region of the lung that's much easier to see.
You really know me.
Yeah, I know. We've worked together for a while now.
So this is zone 4. We did not label it. So this is liver. This is diaphragm. Here's your costophrenic angle. A lot of fluid here. Here's the tip of the lung that likes to live here. I think it's always like South America and Africa, so Gondwana land, right? This little tip fit in here, and then over time, it just separated. So
that's exactly what I was thinking, the exact same thing.
The Atlantic Ocean of pleural fluid. So, okay, good. So let's look at our other side. So this is her left anterior chest wall.
Oh, wow.
What do you see here?
Well, this looks a little different, huh?
Mm-hmm.
So instead of having the anterior effusion and a mass, we have a flat pleural line and lots of flashes of light coming from the top. Looks like many B lines.
Right, good. So B lines on the left side. So your top 2 things in this patient that could cause B lines would be?
Well, we talked about pneumonia, but now something like heart failure or pleural or pulmonary edema is higher on my list.
So it's a little tough to know. There are some studies, not too many, but just looking at pleural line evaluation can differentiate between cardiogenic pulmonary edema and pulmonary process such as pneumonia. In general, this pleural line looks continuous, so it's skinny, it's continuous. There are really no skip lesions.
Right.
And that's more consistent with cardiogenic pulmonary edema than with pneumonia.
So the antibiotics, to me, that I'm with, that's easy. Let's start it. But God,
so now,
do we get fluid
now the question is, do you give her fluid because maybe she has pneumonia and she's septic, or do you give her diuretics because maybe she's got pulmonary edema? So
maybe
what do you want to do?
Let's just give her both and send her to the ICU and put it in someone else's hands. We have to figure that out.
Yeah, good idea. Give her both diuretics and fluid. So, anything else that might be helpful to help differentiate that?
Well, we've already had some success with one ultrasound. Let's ultrasound something else. Let's look at the IVC.
Okay, great. So here's your IVC, and this is exactly the order we did it in too. So
yeah. So it's not the best image in the world, but you see the hepatic veins here. So and you can see your IVC. It's pretty plump. It's not compressing pretty much at all.
That's right. So we know that when it does compress a lot, that's a sign that the patient will probably be fluid responsive, or at least will be fluid tolerant, right? But there, of course, are some conditions that might still mean that fluids would be appropriate in the dilated one.
Right.
However, diuretics might be the right answer in this patient with some signs of pulmonary edema and a dilated IVC. What are some other things that might cause a dilated IVC?
Well, that's the thing. We've talked about this in conference before. If you have large cardiac tamponade or if you have a PE, they're still volume dependent,
Right.
even though they have a plump IVC.
So problems with the right heart might do it. Okay, so let's look at the heart and see if it can be a tiebreaker.
Good idea. Wow. So we have a parasternal long here. This is the LV, and when you look at the ejection fraction, it's pumping pretty good.
Yeah, right. I mean, ejection fraction is it's quite high, right? Those
Yeah.
walls are coming in together.
We know that it is 80%, 90%.
Yeah, just about. And what about the ventricle itself?
So it doesn't look like a ventricle that's in large heart failure. I mean, it's not wide. It's
Right.
nice and compressed.
Well, not nice and compressed. It's just super compressed.
Super
right?
compressed,
It
yes,
is
yes.
underfilled.
Yes,
It
by
is
far
underfilled. So
underfilled.
her left ventricle suggests that she does not have enough fluid in her circulation.
Yeah,
Right?
agreed.
That goes against pulmonary edema. Now, maybe she's got some diastolic heart failure.
Yeah, you could tell
That's a
that maybe
possibility.
because of the LA right
Right,
here.
she does have a big LA, but to say that she's got systolic heart failure and therefore the B lines of pulmonary edema, I think would be a little bit of a stretch. So now, the other thing that can cause a hyperdynamic, or you need to think about hyperdynamic heart with a hyperdynamic underfilled heart would be sepsis.
Absolutely.
And with their consolidation on the right side, it would be tough to justify diuresis in this patient. Now, there's a third option right now, which is do nothing.
Right.
She is hypoxic, we know that, but she's not hypotensive. So one could hold on fluids if this is sepsis until she becomes hypotensive. Or I would probably at least hold on diuretics, though.
Yeah. I think we can agree not to give diuretics. It's tough, God, when you see this heart, tough not to give a little bolus of fluid, but I'm with you. At least no diuretics at this time.
Anything else you see on the echo?
Well, if you look at the RV up here, and after doing multiple echoes now, it looks a little generous. Don't you think? It's a little bigger than what I'm used
Well,
to seeing.
it does. And you know that I like to teach that you shouldn't be using a parasternal long or even
Right,
a pseudo-parasternal long like this to really comment on the RV size, because classically when you're getting a good view of the left ventricle and you've got the aortic valve, left atrium, and descending aorta all in line, you're cutting the right ventricle through an oblique axis. So sometimes you can see some septal bowing, but we shouldn't really rule it out. So if you're able to see that, then great. But the better view is going to be an apical force. So what do you think of this?
Which of course it did. Now, left side is on over here, right side over here, and you can tell, wow, look how dilated that right is.
Yeah.
It's very impressive.
Good. So big dilated right ventricle here. And in comparison, we just put up a case of some normals. So here's the patient. Here's her left ventricle. Underfilled left ventricle with normal ejection fraction compared to a normally filled left ventricle. And here we see a large blown RV. And the RV should be generally about 2/3 the size of the left ventricle. Once it's the same size as the left or larger, then you've got a problem. Now, I'll tell you, we were able to pull up an echo she had from 1 year ago, which showed normal size right ventricle and a well-filled left ventricle. So we were presuming that this was more of an acute process. So what does this do for you?
God, so you have someone who is tachycardic, hypoxic, really tachypnic. You have this large of an RV. I think PE has to move up on the differential.
PE is definitely on the differential.
Yeah.
So, and our differential is still quite broad, right? Is this sepsis with pneumonia causing hypo-filled left ventricle? And is the IVC from cardiogenic shock or from maybe a pulmonary embolism? I think we can say that it's probably not from cardiogenic shock, and the B lines might not be from cardiogenic shock either. So this dilated right ventricle makes us really think of pulmonary embolism.
Yeah, I'm with you.
So our plan was to get a PECT.
Yeah, let's just sign the CT.
Right. Now, while you're waiting for that to happen, because that's not an instantaneous process, is there anything else you can do?
Yeah, I mean, she's not looking too good, so we can't wait for that study. So what about her legs? Let's look at her legs, look for a blood clot.
Okay, so good. This is her right common femoral artery, and here's the bifurcation. Here's the common femoral vein right here, and it bifurcates the superficial and the deep. And so we located those, and then when we went to compress them, sorry the pictures are a little grainy, but when you go to compress, you can actually see, first of all, there's some hyperechoic material inside the superficial femoral vein, and it doesn't collapse.
Yeah.
You can see the deep femoral vein does collapse right here. Split, squish, goes away. This one does not.
Yeah,
And if
clear.
you extend this down to the popliteal, so pop at the top, veins at the top here, so also does not collapse, echogenic material there. So we've just confirmed that she has a DVT. So DVT plus shortness of breath generally equals pulmonary embolism, right? What decision can we make about her treatment right now?
Well, not only do you have that, you have the RV. So you have a very large RV with
That's right.
these findings.
That's right,
So,
and that's a great point. Although I will mention, as you know, that the lack of RV findings does not rule it out. So
absolutely.
if someone comes in, just your 98-year-old, but just your average person comes in with shortness of breath, and you find a DVT, then generally that's going to be a pulmonary embolism. And we know at least what treatment can we give her right now.
So we can at least at the beginning, let's at least start with heparin.
Good. So we gave her heparin right at this time, and this is still probably about 10-15 minutes into her ED course as we're
Right.
ordering the X-ray and getting all the labs in. So we've given her antibiotics for possible sepsis from pneumonia. We're giving her heparin for DVT, probable PE,
Right.
and we want to get a PECT. Now, the challenge was this lady was so hypoxic, worse when she lied flat, that she was not able to go for a PECT. And so we had to make all of our decisions without the PECT. The X-ray, by the way, was this. So does not look normal. She's definitely rotated. The X-ray tech actually pointed out her poor dentition. You don't always see on X-ray, but
And mentioned that her shoulder was in place.
right. No evidence of a humeral fracture. Right? Recommend clinical correlation. Anyway, so they mentioned cardiomegaly, right? And one thing we already have ruled out, tamponade. It's something you should always think about when you see cardiomegaly on an X-ray. They said mild interstitial edema, and we agree with that. And they comment on this right-sided atelectasis, which we looked back, and we actually noted that for the past year or two, she had been having this persistent right-sided atelectasis. So knowing that kind of makes you wonder, is that pneumonia, or is it something more chronic? Does she have a lung mass?
Yeah.
Maybe she had a lung mass that was never really picked up. And of course, the pleural effusion on the right side also.
So this is pretty amazing. You had someone who came to you who was sick as can be, and pretty much in 5 minutes or so, you used multiple ultrasounds, and you had a pretty good idea of what was going on, even without a PECT, even before you got this X-ray.
Yeah, that's entirely true, except the really funny part is that we kind of ruled in that she has a lot of different things.
Yeah.
In this particular
she's sick
case,
for multiple reasons.
multiple reasons, right? And that's always the kicker, right? Like, why are you short of breath? It's always multifactorial.
But we learned not to give diuretics in this case.
Right. And what would have happened if we gave diuretics? I don't know. Maybe we would have dropped her preload and she just would have coded. Or maybe her B lines would have disappeared. I don't actually know. Why does she have this pulmonary edema? I think probably, having thought about this now, probably that mass in the right side was a mass and not
Cancer.
pneumonia. She was afebrile. I still would have given antibiotics, even had I had all the information. But I wonder, did she have that lung cancer and now she had a pulmonary embolism? I'm absolutely convinced she had a pulmonary embolism, despite no CT. And definitely the heparin treatment was right. Now, at this point, so we were considering thrombolytics, and we called the pulmonary embolism team. And we talked it over with them and with the family, and ultimately we all decided that that was a little bit too aggressive of a treatment. In a non-98-year-old person, I absolutely think that right heart strain plus DVT, somebody who's this sick from a pulmonary embolism, you should definitely consider thrombolytics. But the decision with the family was to not be too aggressive with their care.
So, Andrew, take us home. What did we learn just in general from this case?
So, I think that this is a great illustration of a couple of things. One, lung ultrasound can be very helpful, and right off the bat, the X-ray note didn't tell us anything that the lung ultrasound didn't. And I find that to be the case just in general. There are rarely any times that a chest X-ray will tell me something that I didn't already know are fine with pulmonary ultrasound. And pulmonary ultrasound has a higher sensitivity and specificity for pneumothorax when compared to X-ray. It has a higher sensitivity and specificity for pleural effusion
Absolutely.
than an X-ray. So if those are your reasons for getting X-ray, think ultrasound, and maybe you can skip the chest X-ray. There's some data suggesting that lung ultrasound is even more sensitive and specific for pneumonia. Now, that's a much harder exam because you need to look in a lot more different places. And for pulmonary edema, same thing. It's probably, depending where you look, it has similar sensitivities and specificities. Anyway, somebody's dyspneic, there's really no reason to not do lung ultrasound. The other thing that this did for me is I learned a lot just from not just looking at the lungs.
Right.
And had we stopped at the lungs, we would have said this lady's got just pulmonary edema, maybe pneumonia, pleural effusion. I probably would have diuresed her. And I think we would have completely missed looking, entertaining the possibility of a DVT or pulmonary embolism, which I do believe, and again, we had no CAT scan to prove it, but I do believe that's what ultimately was the cause of her dyspnea.
As always, you can ask us any questions, give us comments, please. We love hearing from you guys. mghedultrasound@gmail.com. And Andrew, thanks again for joining us, and hopefully we can bring you back for more of your awesome cases that you have.
Yeah, cool. Thanks,
Cool.
Scott.
Thank you.